If not, then we will have the concluding remarks from the panelists, if they want. And Professor Ra, he is still there with us. Can you hear us, Professor Ra?
Yes, I can hear.
Is there any question, Suhail, from Professor Ra? Professor Ra, if you stuck in SFA CTO, can you tell us a little bit about how to do it retrograde puncture?
Are we offline? Or are we going live? Check.
Which view to use and SFA retrograde puncture?
Retrograde puncture. The most good basic concept is you need to prepare the good micropuncture needle. Mostly frequently using puncture needle is depends on the patient muscle volume. The distal SFA puncture will be requiring mostly 7 centimeter needle. So the core company, they provide good micropuncture needle. So 7 centimeter, the distal below knee puncture 5 centimeter. But sometimes the bulky femoral area, sometimes you need a 9 centimeter needle. So some cases you need the longer needle, but usual distal SFA puncture, 2 orthogonal view, at least 1 view. The key retrograde access is at least 1 oblique view or the AP view. You need to, in single line with 1 needle line to the SFA line, at least 1 needle you can matching single line, then do the going to the single line access. Then depth can be assessed by the 1 orthogonal different angle, so that you can assess the depth. However, many of them have the calcified SFA, so generally just without contrast you can see. Either you can do the fluoroscopic guided access or the ultrasound guided access. But many physicians, by the collateral angiography, you can easily mapping by the angio-guided retrograde puncture. That's not difficult. One mapping to the another monitor, then do the easy puncture. Or the wire mapping in the pull-through man, the contrast to this relative location assessment by the pull-through man wiring to do the just puncture. Once you have some learning curve, that will not be difficult. So that's saving time instead of the costly re-entry device.
Okay, thank you, Professor Ra, for your time. And I know it is 11 p.m. in Korea, and we are about to end our session, but we will see the other case, the subclavian, to see their final result, what they have done so far.
That's very.
Yeah.
Yes, it's very exciting. Okay, so we are live.
So we have 1 minute, 2 minutes.
Okay, let's go back. We did some dilations. Go back for the first dilation. We first dilated with a balloon catheter. Yes. Here.
Next.
Go forward.
Next.
Yes, this is 3O balloon catheter. And afterwards, we dilated with 6O balloon catheter. We do not have here 5O balloon catheter. We do 6.
Next.
Next one.
Next.
Next one. Yes. And as you can see, we have recoil there. We have an under expansion. So we decided to take a cutting balloon there. We have 5O balloon catheter from Boston Scientific. Next. We had a marker there with a needle, and we dilated with 5O by 20 millimeter cutting balloon catheter. Next. Next. Is relatively well expanded. Next.
Next.
And finally, we took 6O balloon catheter. And the last picture.
So this is a Mustang CTO balloon or just plain balloon?
We use POBA, plain balloons and cutting balloons.
Okay.
We have now a small dissection there. It's not flow limiting, and we were discussing with our colleagues, should we place a short stand there or leave it like this and wait and see approach? What do you advise us?
This seems like not a flow limiting dissection. So, I mean, I would take another shot, in a couple of seconds, and if you still see good flow with no flow limitation, then I don't think we will need stent here.
So
yes, we will take a picture for you. Yes. I think
It has worsened.
it will have a thrombus there. It will.
yeah, it has worsened. Probably you will need a stent.
You either need a stent or you can take a balloon, 6.0 millimeter short balloon, and inflate it and just leave it for 2 to 3 minutes. And then take another picture before you put a stent in, because it's a very highly mobile area. And I would really like to avoid stent unless it's really, really needed. So I would do the prolonged balloon inflation here for 2 to 3 minutes at low pressure.
Okay, we did this, but we will do it again, and we will decide after that. Okay.
So you have already done the prolonged inflation.
How long?
4 or 5 minutes.
5 minutes.
They did the prolonged inflation for 5 minutes?
Yeah.
And what was the balloon size?
What was the balloon size?
It should go at least 1-to-1 with the vessel wall. I mean, it looks like...
Yeah, it has to be low pressure and prolonged inflation.
Prolonged inflation, and if it is a 6 millimeter balloon, it has 6 millimeter vessel, it has to be a 6 millimeter balloon. Again, at low pressure, 4 to 6 atmosphere.
You may need multiple time prolonged inflation, 5 minutes, then wait to see, and you can do it again and again. What was the size of balloon for prolonged inflation that you?
6 millimeter, and we did dilation with 6 atmosphere with the nominal pressure.
For 3 minutes or 5?
We can try it once more if you want. We can dilate 4 or 5 minutes and decide.
Yeah, if it is the dissection is sealed with prolonged inflation, that will be good. The area is mobile, and we don't have that supera-like stents in Pakistan, I think.
Yes, supera could be better here. It's we do not stent fracture with that stent, but we do not have it here, unfortunately. I think this will require a stent, a short stent. A 40 millimeter stent here.
So
No. Wire.
You are planning...
Advanced wire. Advanced wire. No. Yes.
Wire position is lost.
Hold it. Yes. Let's give it a test. Just. Yes, good. Maximum 5 atmosphere. In fact, it's not an atherosclerotic tissue, it's fibrotic tissue. We had severe recoil with this balloon. Cutting balloon cut the fibrotic tissue.
So this is 6 mm balloon. 6.0.
6 millimeter, yes. 6.0. by 150.
50. 16 to 80, sir.
Let's look at the watch.
The timer is on. It's about 34 seconds.
Supera would be better here if we are obliged to implant the stent. And the patient feels pain after 5 atmosphere. 4 or 5 atmosphere. Are they still with us?
Sir, are you hearing us?
Yeah, we are with you.
Okay.
We have 4 to 5 more minutes.
Seven,
so we'll see
120.
how you do in 4 or 5 minutes.
Yeah,
And
we are
if
already
things looks
late.
good, great. If not, then we are going to leave you guys alone and do your case, finish your case, whatever the way you want. And you'll probably tell us the result maybe later or tomorrow. So we'll see how it goes in the next 4 or 5 minutes.
640.
Okay, thank you very much.
640. 7, 120, 860. 840 देखें जरा पड़ा हुआ है 740
As short as possible.
yes
Just
640 is available.
but 40 may be undersized.
Okay.
The diameter of the vessel is 6 millimeters, so we should place 7 or 8. Self-expandable must be chosen 1 or 2 millimeters bigger than the index size, not 1 to 1. But Supera, for Supera, you must choose 1 to 1.
1 to 1.
If you choose bigger, it extends. It becomes longer.
Yes.
This is for Supera, the stent where you can decide the beginning, but you cannot decide where it finishes.
Yes.
It's like very interesting.
That's what's with the carotid stent. If the vessel is smaller and you are putting a bigger stent, then it will elongate.
Carotid both stent and both saver stent. The best stent, the sizing is important. They extend.
Yes.
So then you are surprised. It becomes very long. If you take very bigger than the vessel. It's better to choose the size according to ultrasound diameters.
ACT कितना है जी?
We are waiting.
लिया नहीं था? डॉक्टर साहब, ACT लिया तुम्हारा? अच्छा चलो ठीक है बस. मेरा ख्याल है दे देते हैं. It's about 3.5 minutes.
So we are finishing.
We have only 2 minutes.
Short sheet.
RIC, can you hear us?
Yes. Are you still with
We
us?
have only 2 minutes. We can see your case later on or tomorrow if it is not finished within 2 minutes.
Thank you for your patience. Now we
Yeah,
will
you
take
have
a
to be
picture and
patient
decide.
when you are doing peripheral intervention.
It's 4 minutes, sir. 4 minutes.
Okay.
Yeah.
So let's wait for the best. Hope for the best.
Take it out and I can get up pretty wire back.
वायर की टिप दिखानी थी यार.
Take it. Take. Yes. Let's take a picture.
Normal picture or DSA? Normal.
Clearly.
Okay.
I think it looks much better this time, right?
Yes.
Yeah, I think it is acceptable.
Yes, we will take the last picture with subsection angiography. Is it ready? Yes. Okay, we will leave it like this, if you agree with that.
I totally
Yeah.
agree with that.
Totally
the
agree with
dissection
you.
is pretty much gone. There's a good flow distally. Again, this is the area we would like to avoid any stenting. So this is a great case. Thank you so much, guys.
Director?
Thank you very much, the chairperson, the presenter, Professor A, Professor Ambar Malik, who was on virtual, Dr. Tariq Siddiqui, Professor Hikmatullah Jan, Professor Irfan, Professor Elmis, and all the audience, and Dr. Suhail. Thank you very much. With this, we conclude this session. Thank you very much.
French wali.
Okay, so our objectives will be that know the septal anatomy angiographically, because we all know what is interrelated septum. We are not going to that detail, but we will be discussing how angiographically it looks like. And then we will discuss septal puncture and PTMC step by step. And I'll try to finish in half an hour because that is the time we have got. And we will be having we have divided this session into 3 portions. First session that we will discuss the software. We will discuss step by step everything. And then we will take you at the back and we will divide you in 2 groups and you will see the original tools. How does the broken bro needle look like? How does it feel? And then we have got this Mentis here simulator and you will be practicing septal puncture up to this one. We will try to cover the whole PTMC, but the simulator has got limitation up to septal puncture. So this is how we will divide this session into three portions. And finally, perform septal puncture. So as I have already told you that this is interiliac septum and these are important relations. इसका pointer कैसे चले? Okay. So I think it's वहाँ तक आ रहा है, आपको नजर आ रहा है? ठीक है ना? ठीक है, चले इसे. So in this one, this is our interiliac septum, and it depends on from which part you want to puncture and what is the procedure you want to do. If you are basically, as we have already discussed, that this is the portion. ये pointer comes. Okay, so this is a mitral valve, and at the back, you just behind the mitral valve, at slightly posteriorly, you have got left atrial appendage, and then you have got pulmonary veins. So if you want to go for mitral valve, mitral clip, and your consideration is that you want to go into LA and you want to work on the mitral valve, you need to puncture higher and as posterior as possible, so that you get enough working length for the system, because your system needs to stay into LA and you need enough space to work for the mitral valve, and you want enough space for the manipulation of your system. So if you, and in this image we will see on fluoroscopy also, when we say that you want to puncture higher, you want to puncture from the lower end of and as near as possible as aorta. And if you want to puncture lower, you want to puncture as low as possible from the aorta. And the pigtail is the marker in the fluoroscopically. So if you want to puncture higher, you will puncture near as possible towards the aorta. And if you want to puncture lower, and when do we want to puncture lower? Usually in Pakistan we have got this multi-track balloon and we want to try cross mitral valve directly, and the system goes directly through the mitral valve. So in this system we tend to puncture lower, as low as possible, because it's difficult to cross. It's very easy to cross mitral valve in this situation, but you will not have any working length available for your system. So you won't be able to manipulate anything. It will directly cross mitral valve, but you will not have enough space to manipulate your system. So if you want to puncture higher, you will try to stop near as possible towards the aorta and puncture it. Similarly, if you want to puncture anterior, you would like to puncture as near as possible towards the mitral valve, and if you want to puncture posterior, you will try to go as behind as possible from the mitral valve. But this you cannot assess clearly in this view. You need to go into lateral view. We will see. It's going to come in next images. So this is a conventional image. We are all familiar with this image from the beginning. This was a traditional way of puncturing, that you draw a line from the lower end of the aorta and then from the superior atrial boundary, and then from this boundary you try to puncture at this point. This was the conventional way. Traditionally it was told, but these were the days where the only target was to do mitral commissurotomy. But nowadays you are going to LA for LA appendage closure. Sometimes your aim is to close LA appendage. Sometimes your aim is to ablate pulmonary vein. Sometimes your aim is to do a mitra clip. So it depends on what is your aim. That's why you try to puncture higher, you try to puncture lower, you try to puncture anterior or posterior. It depends on what is your target. Okay, so this is an image. Basically, we took just to give you orientation of anatomy. So we just injected into LA, and this is how this anatomy is. That you have got mitral valve here, you have got this LA boundary here, this is the appendage. So we took this image. इसको मैं दोबारा रन करना चाहूँ तो दोबारा रन कैसे होगा? Back. Okay, this is another image. This is just to make the orientation. This patient had severe MR, we injected, and now you can see where is mitral valve, where is LV, and this is the appendage, and you can clearly see what is the anatomy. So this is how our heart is placed angiographically. So we need to have, and this is the septum. You see this is the septum. Okay. So any question up to this point? Okay, and then we had another patient who had severely calcified atrium. So that made us know how does atrium boundaries look like. This one again, severely calcified atrium. And you can see how is the orientation of the septum. So before we proceed for the step, we need to know the tools, and you will be able to manipulate and see all of these tools. They are behind at the table. So there are three basic things. Mullen sheets, usually it's H8 French sheet, which has got 59 centimeter length, and then we have got this dilator of the Mullen sheet, and in no point you will withdraw this dilator, because this dilator is going to occupy this needle inside, and this is for the protection of this so that it will not puncture the septum and this sheet and come out of the system. So dilator inside, dilator is slightly longer in length in this one, and then broken bro needle, which is 71 centimeter. But I will warn you that please look at the system, because they come in different lengths, and in our in hospital also we have got some puncture needles which are longer in length, because you are in confidence that this is just slightly 3 centimeter, 4 centimeter longer this one. Sometimes you have got this is 8 centimeter longer in this one, and you are just pushing it blindly in the confidence that it will not come out of and it usually comes out of this needle and it will puncture an abnormal part. So we need to check in our hospital then what are the systems available, and before every procedure you check all the systems. And then this needle comes out of the dilator and it will help in puncture. Dr. Irfan and Dr. Tariq Ashraf will tell you this thing clearly. And this is the broken bro needle, and this is the pointer, and when we will be discussing steps, What do we mean by 3 o'clock? What do we mean by 4 o'clock, 6 o'clock? Say it is like this, that when you place this needle and towards the left of the patient, it's 3 o'clock. Towards the right of the patient is 9 o'clock. So when you are performing the procedure and when you're taking the needle inside, towards the left of the patient is 3 o'clock, towards the right of the patient is 9 o'clock. And what is the optimal position for the puncture, we will see. So the steps, usually we start with taking a wedge pressure. And usually this is for the, usually these steps for the PTMC. Basically, you may not need it. But usually we start with taking a wedge pressure, or usually PA pressure is also enough. Usually just to pick up any tamponade as early as possible, we try to take a baseline image of the heart, and so that you have got these heart boundaries, because patient may collapse later, patient may develop signs of tamponade later, but the initial sign is that you see the effusion outside, and you see that is the earliest sign you will see. So if you got this baseline image, it's easier to pick up any abnormality. And the first step is usually we take a 3-2 wire, normal J-shaped 3-2 wire, and we park it into superior vena cava. And it does not require any special manipulation, because IVC and SVC are in straight line. So if your system or your wire does not have any bend, it should automatically go into SVC. But if you have any difficulty, you can take a multi-purpose and just keep it straight and push it from SVC. It will directly go IVC and it will go into SVC. Once it's there into SVC, then comes the Mullen sheet. Mullen sheet is 8 centimeter, and then it will slide. Everything is done under fluoroscopy. And this Mullen sheet will go into SVC. SVC, it doesn't matter in which branch it's lying down, because you just want to stay into main SVC and you have to drop it down. Next step is you take the broken bow needle inside. The broken bow needle going in. Dr. Tariq Ashraf and Dr. Irfan will tell you that how to keep your fingers in control. So usually, just before you try to make a safety lock by making your finger in front of this metallic marker which we just told you, and Dr. Tariq Ashraf and Dr. Irfan will tell you that what will be your hand position when you are taking this broken bow needle inside, because that is a very important step, so that you do not come out of this Mullen sheets dilator accidentally. So you keep your finger in front of your marker. That you will see in this steps portion. Next step is that you try to define your level. And that's what I was telling you. This is pigtail. And if you want to puncture higher, you should stop at the level of the pigtail. If you want to puncture lower, usually you see one vertebral disc below this pigtail. So traditional way of doing PTMC is we stop one vertebral disc below the pigtail. So it means you want to puncture lower. But if you want to puncture higher, you will stop at the level of pigtail. It depends on what is the procedure you want to do. So if you want to go for a mitra clip, you want to puncture higher, you should stop at this point. Traditionally, it is told that you will feel 3 bumps. But I never felt. Dr. Tariq Ashraf usually able to feel those things. So it's difficult because different people have different anatomies, and usually the patients have got hugely dilated LA, which is protruding into right atrium, and usually I am unable to feel any drops, because traditionally it is said that when you cross the SVC, enter into right atrium, you will feel a jump. And then when you come into fossa, you will feel another jump. But most of our patients, they have got hugely dilated LA. LA has already jumped into right atrium. So usually we don't feel those bumps. So I will suggest people like me who have got different blunt feelings that just believe on fluoroscopy, because the people are different, patients are different. Next is so we have defined in this patient that we want to go puncture lower, so we pigtail and we want to go one disc space below. But now I want to define, I want to puncture anterior or posterior. So we go into a left lateral 90 position. And this is the anatomy in this image. As we have already discussed, I think those who have joined later, that in this image we are somewhere here. This is our needle, and aorta is somewhere here. Sorry, our needle is somewhere here, and aorta is here. This is mitral valve, a tricuspid valve, and this is coronary sinus. Sometimes if you come much more lower, there are chances you may drop into coronary sinus if it is dilated. So we need to be careful. We had one patient with tamponade in which accidentally it jumped into coronary sinus. My message is that if you are sure you are into coronary sinus, don't try to manipulate and turn it towards the right atrium. Just bring it down, put the wire again, go up and come back again. Because coronary sinus is a frail portion, we had tamponade in that patient because we just rotated into clockwise and came back into right atrium, pushed up, punctured anti LA, and when we completed, we found that the patient was having tamponade. So the only step was that we accidentally fall into coronary sinus, and just in overconfidence, we thought that I can just simply pull it back and manipulate it and keep it in the normal position and then puncture it. We did it, but in this manipulation, because this balloon sheet has got the needle inside, it becomes stiffer, so it dissected the LA. So next is, I'll come back in this one later. First, I want to tell you this thing. I'll come back to this image later. So this is left lateral position. Left lateral, you have got pigtail in front, you have got a spine at the back, and you have got this septum. So I just told you that this septum has got a vertical part and a horizontal part. I just want to prove it. I will prove it. This is when you have got fellows in your cath lab, you find this kind of thing. So what happened that accidentally he went into vertical septum and injected into vertical septum and dissected the septum, but I took this image for the anatomy. So this is in the lateral view, you have got this vertical septum, and then this septum becomes horizontal here. And mitral valve in this image is towards me, it's towards you. So if you puncture from here and you want to come towards your side, it won't be possible. It will be very difficult. So you always try to puncture from the horizontal part, from this part, so that it will be easy to manipulate and it will come towards your side. So this is vertical septum and horizontal septum, and but you don't see anatomically. What you will see like this. And then what is your anatomical part? Usually from the pigtail and the spine, you divide this one into 3 segments. And we try to puncture in the middle part. If you are puncturing in the front, you will be very anterior, and if you puncture at the back, you will be very posterior. And how would I know that I am puncturing at the back and front? With this angiographically, plus I am going back to this image. This one. So when this is my heart, right atrium, right ventricle, right atrium, and if you your needle, when you are 3 o'clock, your needle is pointing here, and if you puncture here, you may go into directly into aorta. So what you want to puncture is you want to keep your needle position from 3 o'clock to 6 o'clock. So this is your working area, and you want to puncture here. So it's very important, and geographically, sometimes your heart may not give you a clear orientation. Angiography will not give you a clear orientation. Most important thing is your hand position. If whatever you are looking at, but if your cursor is, if your pointer is pointing 7 o'clock, you will go out. If your pointer is going 9 o'clock, whatever angiographically it looks like, it will go out of the heart. So this is the point, 3 o'clock. So usually from 5 o'clock to 6 o'clock, 4 to 6, this is the portion where you want to puncture. So it's important to keep control of your pointer, and this you will see in your hands-on session. So next is, you have already seen. Next very important thing is that some of our experts, like Dr. Ishtiyaq especially, I've learned from him a lot, that he used to stain the septum, so that it will give you a marker that what was the puncture point. So whenever then you feel resistance, they used to give a little bit of dye and you stain the septum. The important is that sometimes you have got floppy septum and the septum tends up. And when the septum tends up, you are very near to the posterior wall. So as soon as you will puncture, and if you are not aware of that, you have already tented up, you will puncture the posterior wall because you are forcing and you won't be able to stop, and this will puncture the posterior wall and you may have tamponade. So another important thing is, so when you puncture, we inject, and traditionally, and it's very important, don't take it light, you inject and take a cine. Because if you are in LA, the dye will stay for a while, it will whirl, and you will see the distance of your needle and your system, so that you will know that how much further I can push. Secondly, and I will show you some images, how important this one is later on. Okay. Next is that you hold the system and then you bring the sheet forward. Once your sheet is inside, you rotate it back towards 3 o'clock, because your mitral valve is towards 3 o'clock, and you puncture towards 6 o'clock. And you want to come back, you want to rotate system. So usually, Dr. Tahir Zaghir always say, rotate anti-clock, rotate anti-clock, rotate anti. So we used to say, what do you mean by anti-clock? So basically, you have, when you are puncturing, you punctured the septum and your needle was directing 6 o'clock, 5 o'clock. But your mitral valve is towards you. So you want to rotate the system again 3 o'clock. So 5 o'clock to 3 o'clock again, it means you want to rotate anti-clock. So when you rotate anti-clock, there will be more chances that you will cross mitral valve easily. Then you come back in your working image, which is usually RAO30. And then you push your system forward. If you can easily cross the pigtail marker, the shaft, you are in LA. But important thing is, most of the time it tends to rest into appendage. So next step is that you take the wire in, and wire, like in this patient also, was trying to go into appendage, and appendage is a softer part. So when you push the wire, there will be chances of appendage rupture. So don't push wire when you are in the appendage. Just pull back the system, it will fall out of the appendage and you will be near to the mitral valve. Then the wire is there, septal dilator is 14 French, and septum is somewhere here, we already know. So you need to feel when you are dilating system, and by up till the point you are feeling resistance, it will be better that you just keep on dilating 3-4 times so that you don't feel any resistance and the septum is clearly dilated. Next, you take the balloon system in. This balloon, what are the parts? We have got these balloons at the back, I think, and Dr. Tariq Ashraf and Dr. Irfan will tell you the different parts of the balloon and how does it work, what is the stretching tube and what are the different parts and how do we do it. Next step is how do we cross it. So you take the wire and everything out. Take the wire out. So the system is ready for the work. Then we have got this metallic stellate in. The stellate goes in. The stellate goes in. And now how to manipulate. So how to manipulate. The important thing is this stellate is a stiff hockey shaped structure. This stellate is not meant to cross the mitral valve. If you push it forward, it will go up, like what I did. Now when I push, it goes up. We feel that when we push it, it will go down. When you push it forward, it will not go down, it will take the system up. So once you are there and you are in the LA, you rotate anti-clock again, as I told you, Dr. Tahir Saghir's traditional words, rotate anti-clock, rotate anti-clock. It means that you are going near towards the mitral valve. And then you slide the balloon forward. Usually in a way it's safer because it does not go over the wire. It will just make its way and it will tend to slide. This is how we see. When I am trying to push this stellate up, it's going up, it's not going down. The stellate is taking the system up, taking it away from the mitral valve. So pushing is not going to help you. You are just going to rotate anti-clock. And once you are there, you will try to slide your balloon forward. And it will cross. And when if it's crossed, you will inflate half, pull it back. When you feel resistance, inflate complete. Okay, and again, slide the balloon forward. The stellate is not going to go into LV. The stellate is just going to direct you towards the mitral valve. The balloon itself is going to slide in. You need to hold the stellate and slide the balloon forward. So it will make its way. And some of the people suggest that sometimes it's difficult. You can inflate it 2 to 3 cc, and then so it will follow the flow. I try to be quick. Sometimes reverse loop. Reverse loop is comparatively if you have punctured near to the mitral valve. And sometimes your wire position also tells you that you have punctured anteriorly. Because when you push your pigtail wire and it's making your loop in the front, it means that you have got enough working space here. But if your wire is making a loop behind, and you are not able to turn it towards the mitral valve, you won't be able to, you mean that it will not go directly, you don't have enough working length for the metal, for this NOA balloon. So the wire, you slide the whole system over the same wire and you roll it, and then you bring the wire back, pull the wire, the balloon will fall into the mitral valve. Once it falls, you are into the LV. Then there are two techniques. One is like this. You inflate directly, pull it back, pull it and inflate completely. But we have learned from our experience that in this position you are not in the right orientation with this mitral valve, because mitral valve is oriented like this and your balloon is oriented horizontally. So in this one we had few cases with severe mitral regurgitation. We had cleft the mitral valve. So now what we practice that once we have crossed, we inflate balloon half, and then this reverse loop, make this loop untied, and then we pull it back again, like this. Okay. So complications, I'll be quick, but just what I have told, like floppy septum, I've just told you that this is important because your distance between your needle and the posterior wall will be very short, and you will be afraid of puncturing the posterior wall. The distance here is quite short, so you can, if you bring your system forward, you are afraid of puncturing the posterior wall. Similarly, septal dissection, and it's important that you be aware of that, and this is important because the needle went into the vertical septum, and when they injected, it stained the whole septum. It usually resolves itself, does not cause any complication, but this is one of the issues we need to know, that it helped us in this patient to identify the vertical septum, and we bring the needle back and puncture it from the horizontal septum. Next, we injected, we found something weird. The dye is not making that clear whorls. We stopped, but unfortunately we had already forwarded the Mullen sheet. So when we found this position, we knew that the operator was not looking in 3 dimensions. He was looking in 2 dimensions. He had already rotated the cursor up to 7 or 8 o'clock. So we have already punctured, and the Mullen sheet is there. And just to confirm, we injected and we were in the pericardium. And I think that you don't have to worry about it. Just leave, don't do anything, just stitch it and shift the patient for the surgery. Some other people may think of closing with the device, but this patient is already, again, needing a metal gummasherotomy. You have already got tamponade. So we shifted the patient to the theater, and the patient was done safely. And that's what I was asking, that don't skip this one. Once you inject into the normal LA, you will see like this, but sometimes you may see this. So they have punctured aorta, the needle is in the aorta, you have done coronary angiography simultaneously, but again, if you have not pushed your dilator forward or your Mullen sheet forward, the needle puncture is usually sealed by itself. So, so the patient was uneventful. We complete the procedure at the same time. But this is one of the complications. Similarly, previously when we used to do with the double balloon, this is a double balloon technique. The wire used to rest at the LV apex, and there were a lot of chances of LV rupture. So we used to see a lot of severe MR and the balloon rupture, because these balloons were used to be re-sterilized many times. So this is something, balloons may rupture, but this is not for the NOA balloon. You may have bubbles inside the balloon. sometimes you may see this. Once you see, okay, please look at, consider, focus on the balloon tip. When balloon is inflating, you can see some tapering at the balloon tip. And it's taking some time for the inflation. So usually this indicates subvalvular disease. So again, in these kind of patients, you need to be very careful. I'll be skipping few things. Yes, this is important. We always ask that when you are inside, when your needle is inside and your Mullen sheet is there, please try to keep as little as possible distance in the Mullen sheet and your needle. Because what can happen if your needle is far behind, you are afraid of abnormal puncturing. The plastic portion, when you are pulling it back, may bend. And once the plastic portion bends and you bring when you push the needle may come out of the side of the Mullen's dilator. I'll show you. In this portion, they punctured the LA, but you see the plastic portion is there. Fortunately, when they took the cine and they injected, they found out this is something abnormal. And when we took out, we found this. So the needle was far behind, the plastic portion bent, and when they pushed the needle, it came out of the side. So these are important things, I think. And I'll skip. I think ये आगे और लंबी चीज़ें, I think ये बाकी काम पूरा कर लें. Sorry?
You elaborated very nicely the puncture of the facility. But during your training in integrated hospital, more than 90% of cases that we use to grasp the integrated surgery to the stretch PF.
हाँ, इसके लिए तो अभी आपको डॉक्टर इरफान इस वाले के अंदर आपको दिखा देंगे. वो तो मैकेनिकली उसके अंदर ही है, बिकॉज के हमारा जो एम है अभी इस वक्त के अंदर वो सिर्फ PTMC के लिहाज से नहीं. हमारी जो फॉरेन फैकल्टी है, स्पेशली दे आर मोर इंटरेस्टेड इन माइट्रा क्लिप एंड दे वांट टू नो व्हाट इज इंटीरियर, व्हाट इज पोस्टीरियर, बिकॉज यू डोंट वांट टू गो इन ऑल केसेस थ्रू PFO, because we are doing NOA and this PFO is higher and posterior. So whenever you cross through PFO, you are always higher and posterior, and for NOA balloon it's easier to do it. That is the conventional way of doing it. And different experts, I know some of the people I've heard, they used to even puncture, they don't go into lateral position. They just manipulate into AP view and they know what is the anatomy and they go into LA. So there are different ways of doing it. This is the way how we do it, and we have learned these things because the spectrum for and the I'll say the utility of it in a septal puncture is increasing. And it depends on what is your target. If you want to go for LA appendage, you want to go lower and different. If you want to, they are puncturing septum for ablation of pulmonary veins. So it will be difficult if you have gone through PFO. It will be difficult to go into pulmonary vein. So I think that there are different ways of doing these things. Okay. So I think that yes, please. Okay, basically LA clot, they have a traditional, if you go according to the guidelines, they say LA clot, don't do it. Simple. But ये इससे आगे मैं स्लाइड आपको वही दिखाने वाला था, लेकिन मैं आगे जाना नहीं चाहता क्योंकि हमारे और बाकी सेशन शॉर्ट हो जाएंगे, या फिर हम एक ही को पूरा कर लेंगे 10:30 बजे तक चलाते हैं. तो इट्स ऑन यू. लेकिन LA clot, they have डिफाइंड डॉक्टर तारिक अशरफ एक बुक आपको जो है वो रिकमेंड करेंगे स्पेशली, जिसमें वो ख़ुद भी ऑथर हैं। उसमें जो है वो LA क्लॉट को उन्होंने 4 स्टेजेस में डिवाइड किया है, और उसके अंदर उन्होंने अपेंडेज के फुल ऑफ अपेंडेज, आउट ऑफ अपेंडेज एंड अलॉन्ग विद द LA वॉल। द खुलासा उसका ये है, द सिंपलेस्ट पॉइंट इज़ दैट इफ़ इट इज़ लोकलाइज एट द टिप, you can attempt and go for PTMC. One thing. Another thing is that if you have got thrombus and you want to avoid going into LA appendage, puncture lower and anterior. Lower and anterior. Lower anterior means that you are very near to the mitral valve. Whenever as soon as you will enter into the LA, you will cross the mitral valve. But it will be very difficult to go with the NOA then, because NOA needs your working length. NOA को काम करने के लिए जगह चाहिए.
Basically, this is classification of clot. So if you can do it without this clot coming into the path of the catheter, the balloon catheter, that's low risk. Means if it is sitting on the interatrial septum, you will directly hit it. If it is lying free, again it will go directly. But if it is localized to the LA appendage, especially the apex of that, then probably you can avoid. If an experienced operator is avoiding going into the, like he said, that we will go with lower and directly into the mitral valve, avoiding going into the LA appendage. So that is the low risk, and that is Manjonath classification. You can go through it on the net.
Okay, I think please, if you can, because we have got this portion also, and we have got, I think, half an hour left. So I've already...
just a comment on this, that when you are looking forward to do PTMC with a clot in LA, don't forget that you have to treat that clot as well. So the one reason for sending that patient to the surgeon is that he'll take out the clot as well, and he will sort of ligate the LA appendage, and will partially make the life of you as a consultant cardiologist for monitoring INR and everything easier. So you're not only in a patient with clot in LA with mitral stenosis, you're not only dealing with mitral stenosis itself, you have to take care of the clot itself. So the better option in such patients is that if you can delay, you give them slightly high dose oral anticoagulation, keep the INR above 3, 3.5, around 3, 3.5, and do serial transesophageal echoes to see if the clot is dissolved or not. If your transesophageal echo team tells you that the clot is dissolved, then you stop the anticoagulation, put them on heparin or low molecular weight heparin, and bring them on the appropriate time to the cath lab and do the PTMC. So keeping the clot in LA and then doing the PTMC and not knowing what will happen to that clot in future is putting the patient on excessive risk of thromboembolism in future.
So I will request that we have got around 20-30 people. If you divide into two, and कुछ लोग जो हैं अभी वहाँ चले जाएं पीछे टेबल पे डॉक्टर तारिक अशरफ के साथ में, और कुछ लोग जो हैं वो यहाँ आगे आ जाएं डॉक्टर इरफान के साथ में मेंटिस के ऊपर, देन वी विल शफल. सॉरी, लेक्चर अभी एक और भी है, अगर आप चाहें वो अगला वाला. नहीं, इसके अंदर 2 वर्कशॉप है ना, अभी इसके बाद एक और भी है.
Hello. life situation. The catheters are shaped like, they are cut. If you go with the curved shape, it will not go into this. So this will only just detect the catheter. You put the one, you label it there. This is, suppose, this is the guide wire. So it will take it as a guide wire and you go with the guide wire. Then the next, you take the Mullen sheet, so it will take it as Mullen sheet and you go with that and manipulate like this. Again, the Mullen sheet dilator, like you do, and you will also be doing it there practically on the, or inventory there is available for this. So here it will be just anything you put in this and you label it, it will take it as like this. So this is virtual, real virtual. It's not practical like this one. But the basic thing is, if we want to show the anatomy here, which cannot be created like we do the thing. I have a presentation on it. Probably in the next session I will do some troubleshooting and the way we function. That's another. So the first thing we do here, you all concentrate here. It is, this is the fluoro, this is the cine, like in the real life. Okay. These are the things. You do the fluoro. You come here, caudal, and this is the cephalic. Okay. And like you also change angles. Okay. So these things can be done quite nicely, and you change the field according to with these probes. You can change the tube, and here you can change the table position. Okay. Now what we do, we select a wire. First, what we do, what are the steps? We first make both the venous and the arterial puncture. Usually we save one sheet, so what we do, we make a puncture, we put a wire of the sheet, then we put the dilator, put a small J-tech wire, and then we remove that wire and put another wire, which is 3-2 wire, and that we put into it. So sometimes what happens that this is the vein going, iliac vein going like this. We put the dilator like here. So the dilator, it comes at the tip of this. So what happens that the wire doesn't go. The trick is that you just slightly pull back and the wire will move up. You understand this?
Yes.
So this is practical life in that. Again, in all the tributaries, it will be stuck somewhere, like in the renal veins, like in the other, it will get stuck. So everywhere it stuck, it sticks, you pull back on it, do a fluoro, never go without fluoro if there is resistance. And if you go against the resistance, you will create a trouble. And mind you that venous pricks, they will not be evident on the table, and they will later on be a very big trouble. Okay? And if you close it percutaneously, again that is very difficult, because you know if that is a stagnant circulation, and the clot can form very easily. Okay, so you reach to the SVC. Okay, and then you follow the thing, the Mullen sheath and the dilator.
Yes.
So let's go, if we can just, because this thing, like you, I am also seeing it for the first time. So maybe I may not be that apt in this thing. So just I want to,
just feel it.
We are learning together. Okay. You, I am not a proctor on this. I am just, as you are student, I am a student of this. He's going to.
Everyone is a student.
Yes. Life lab, everyone is a student, but no one is proctor and no one is all are student, and we are learning. And by the way, the person who is doing it, he says that I am engineer.
Yes.
So he's again not a doctor, or so that's much difficulty. Yesterday we sat for around one hour, and we could just only manage to manipulate the things. So sorry for that, because I may be able to do it on that, but this was allotted to me. I have no way out. Okay, put the wire.
I'll just make it clear before this session. This is virtual reality based. There are proper steps to follow because sensors are there. If your technique, if your maneuvering is not correctly, if your insertion, then ultimately the system will not detect. In real, you can go with your own pace. Okay? So these are some limitations. So it's based on expertise level to just configure that.
Like yesterday night, we were missing on one step. That was just flushing. What was that flushing? Flushing is virtual here. So if we were not flushing, the thing was not going. So this make you to go according to a system. Just put the start the thing. This is a TE image. Usually we don't have the TE image, and we don't have the TE Pro. In the and here you will see that there is a TE Pro line here. So we don't do the thing with TE.
यहाँ पे डिटेक्ट करेगा तुम्हें पता बच्चा है अंदर नहीं समझता वो खाना है this will turn into white.
When you are manipulating this, you can just go
we are upward. We have put that wire.
You have gone up.
Yes, I have already gone.
You have
नहीं ऊपर नहीं गया
अच्छा नहीं है
अब आप पुश करें वायर कहाँ है हाँ now it will automatically
वायर है किधर ये सर वायर
अब आ गए आप so femoral axis के through auto tracking के through हम जा रहे हैं so सर ये यार super vein cable में
there is a system auto tracking and there you can go manually with these buttons.
You can auto track any tip which you are introducing.
Okay. So now you are at the SVC.
नहीं
Doesn't matter if you want to be if you want to be in the SVC or you go to the nominate. I personally would prefer to go into the nominate. That will tell me that the nominate vein is right there and the coronary sinus will not be dilated. Are you getting my point? If my catheter is not going into the nominate vein, that means that we have a left-sided SVC, and that will give you a big coronary sinus. And like they had a puncture of the coronary sinus, so we are all having a chance of piercing there. So it is very important to know about these things. But if you cannot go to the nominate vein, well and good, you can. This is the Mullen sheet. Now, this is
नीचे आए बस ठीक
okay.
वायर होल्ड
Thank you.
तो नीचे करो टिप दिखाओ
ये है ना अच्छा
वहाँ से बहुत मुश्किल होगा हमारे
इसके बाद आपने डालना है मोलन शीथ डायलेटर। पहले मोलन शीथ जो होती थी जो करते थे पहले तो उसमें डायलेटर नहीं होता था, अब इस मोलन शीथ में डायलेटर है तो डायलेटर और ये अच्छा है। पहले जब शुरू में आए थे तो हम तो उसके साथ आदी थे तो बड़ी मुश्किल पेश आ रही थी ना, बट दिस टाइम नाउ वी आर क्वाइट ओके विद दिस एंड प्रोबेबली वी आर नॉट गोइंग टू यूज दैट एनी मोर द अदर वन। ये जो कैथेटर नजर आ रहे हैं इसको हम वो नहीं कर सके, लेकिन दिस इज कोरोनरी साइनस कैथेटर प्रोबेबली। डायलेटर डाला है, डायलेटर डालना है। वो डायलेटर आप जब डालेंगे ना उसके लिए वायर की इतनी जरूरत नहीं है।
असल में ये बुलेट शीट तो रेडी होती है ना, वो यही कह रहे हैं हमारे साथ
अब यहाँ से सिलेक्ट करना होगा ना, डायलेटर को सिलेक्ट करेंगे ठीक है।
ऊपर दिखाओ नहीं है
ये देखें ना, ये आप खुद ही करें।
ऊपर तो दिखाओ।
नहीं, आप करें ना।
मैं तो कर रहा हूँ।
नहीं, इधर से करें ना, ये भी आप करें। आप चले, आप चले, सही है, सही है, आपके लिए मैं करता हूँ। ठीक है, आपका वायर बहुत वो है ना।
हमारा ऑपरेटर वैसे एक बात है।
ये मेरे ख्याल में ये काम जो है ना, ये एक बंदा करे, क्योंकि अब 2 बंदे कर रहे हैं ना, तो आपके मतलब कोऑर्डिनेशन सही नहीं आ रही है। हाँ, नहीं, ये लूप के साथ नहीं जाना चाहिए। वी नेवर गो विद दीज लूप्स।
इसके साथ
हाँ। अच्छा, ठीक है, मतलब वो इधर आएंगे, वो life situation. The catheters are shaped like they are cut. If you go with the curved shape, it will not go into this. So this will only just detect the catheter. You put the one, you label it there. This is, suppose this is the guide wire, so it will take it as a guide wire, and you go with the guide wire. Then the next you take the Mullen sheet, so it will take it as Mullen sheet, and you go with that and manipulate like this. Again, the Mullen sheet dilator, like you do, and you will also be doing it there practically on the inventory there is available for this. So here it will be just anything you put in this and you label it, it will take it as like this. So this is virtual, real virtual. It's not practical like this one. But the basic thing is, if we want to show the anatomy here, which cannot be delineated like we do the thing. I have a presentation on it. Probably in the next session I will do some troubleshooting and the way we function. That's another. So the first thing we do here, you all concentrate here. This is the fluoro, this is the cine, like in the real life. Okay. These are the things. You do the fluoro. You come here, cordon, and this is the cephalic. Okay. And like you also change angles. Okay. So these things can be done quite nicely, and you change the field according to with these probes. You can change the tube, and here you can change the table position. Okay. Now what we do? We select a wire. First, what we do? What are the steps? We first make both the venous and the arterial puncture. Usually we save one sheet, so what we do? We make a puncture, we put a wire of the sheet, then we put the dilator, put a small J-tech wire, and then we remove that wire and put another wire, which is 3-2 wire, and that we put into it. So sometimes what happens that this is the vein going, iliac vein going like this. We put the dilator like here. So the dilator, it comes at the tip of this. So what happens that the wire doesn't go. The trick is that you just slightly pull back and the wire will move up. You understand this?
Yes.
So this is practical life in that. Again, in all the tributaries, it will be stuck somewhere, like in the renal veins, like in the other, it will get stuck. So everywhere it sticks, you pull back on it, do a fluoro, never go without fluoro if there is resistance. And if you go against the resistance, you will create a problem. And mind you that venous bricks, they will not be evident on the table, and they will later on be very difficult. Okay? And if you close it percutaneously, again that is very difficult, because you know if that is a stagnant circulation, and the clot can form very easily. Okay? So you reach to the SPC. Okay? And then you follow the Mullen sheath and the dilator.
Yes.
So let's go, if we can just, because this thing like you, I am also seeing it for the first time. So maybe I may not be that apt in this thing. So just I want to, we are learning together. I am not a proctor on this. I am just, as you are student, I am a student of this. He's going to.
Everyone is a student.
Yes, lifelong, everyone is a student, but no one is proctor, no one is all are student, and we are learning. And by the way, the person who is doing it, he says that I am engineer. Yes. So he's again not a doctor, or so that's much difficulty. Yesterday we sat for around one hour, and we could just only manage to manipulate the thing. So sorry for that, because I may be able to do it on that, but this was allotted to me. I have no way out. Okay, put the wire.
I just make it clear before this session. This is virtual reality based. There are proper steps to follow because sensors are there. If your technique, if your maneuvering is not correctly, if your insertion, then ultimately the system will not detect. In real, you can go with your own pace. So these are some limitations. So it's based on expertise level to just configure that.
Like yesterday night, we were missing on one step. That was just flushing. What was that flushing? Flushing is virtual here. So if we were not flushing, the thing was not going. So this makes you to go according to a system. Just put the start the thing. This is a TE image. Usually we don't have the TE image, and we don't have the TE Pro. In the here you will see that there is a TE Pro sign here. So we don't do the thing with TE.
अंदर नहीं समझता अंदर नहीं समझता डिटेक्ट करेगा तुम्हें पता बच्चा है अंदर नहीं समझता वो खाना है बार दे
this will turn into white.
When you are manipulating this, you can just
नहीं बोलता
go.
We are upward. We have full time wire.
You have gone all
Yes, yes, I have already gone.
नहीं ऊपर नहीं गया.
चली गई.
अब आप पुश करें.
वार कहाँ
हाँ. Now it will automatically.
वायर है किधर?
ये सर वार
अब आ गया. So femoral axis के through auto tracking के through में आ गया.
सर ये याद रखना रेडिएशन ज़्यादा नहीं खाना.
There is a system auto tracking, and there you can go manually with these buttons.
You can auto track any tip which you are integrating.
बस सर बस गले में
नहीं है
SPC में
Doesn't matter if you want to be.
फुल एग्जीबिशन आ रही है.
If you want to be in the SPC, or you go to the nominate. I personally would prefer to go into the nominate. That will tell me that the nominate vein is right there, and the coronary sinus will not be dilated. Are you getting my point? If my catheter is not going into the nominate vein, that means that we have a left-sided SPC, and that will give you a big coronary sinus. Like they had a puncture of the coronary sinus, so we are all It is very important to know about these things. But if you cannot go to the nominator, well and good, you can.
ये जरा इसको नीचे लाएं दोबारा ग्राउंड में.
This is the Mullen shape.
हाँ ले जाएं सर मोलन ले जाएं. इस को दिखाते जाएं मोलन.
नीचे है बस ठीक. वायर होल्ड
है सर. ठीक हो गया.
थोड़ा नीचे करो टिप दिखाओ. पूरी तरीके
ये सारे यहाँ से हम करेंगे. वहाँ से बहुत मुश्किल होगा हमारे लिए. यूनिवर्सिटी में हम जाएंगे और जो भी आप ऑटो टेक करना चाहें
तो गई है ना.
पहले मुलन शीट जो होती थी, जो करते थे पहले, तो
चली गई. ऊपर करो ना.
ऊपर दिखाना. थोड़े पीछे
तो डायलेटर और ये पहले जब शुरू में आए थे तो हम तो उसके साथ आ रहे थे, तो बड़ी मुश्किल पेश आती है. But this time now we are quite okay with this, and probably we are not going to use that anymore.
So these are the features. जो भी आप यूज करते हैं उसको ऑटो ट्रैक करते हैं. बस सर. So now we are going with.
हाँ अब वार निकालनी. सर आप बोलते हैं वार निकालनी.
डायलेटर आपको
नहीं
डायलेटर डाला है?
डायलेटर नहीं डाला, डायलेटर तो डाला नहीं।
इसी वायर के ऊपर ही डायलेटर लगेगा।
वो डायलेटर आप जब डालेंगे ना उसके लिए वायर की
असल में ये मूलिंग शीट तो रेडी होती है ना, हम लोग पूरे दूसरे नहीं, ये वो यही कह रहे हैं कि डायलेटर हमारे साथ होता है।
यहाँ आप सब कुछ खुद ही करें।
नहीं यार, ये चॉकलेट दिखा के कहते दवाई है, दवाई को दिखा के चॉकलेट है।
नहीं, ये इसमें
डायलेटर यार नहीं
ये भी वही कह रहे हैं जो डायलेटर में क्या। अब यहाँ से सिलेक्ट करना होगा ना, डायलेटर को सिलेक्ट करेंगे।
डायलेटर
ओके,
मैंने अरशद साहब को बड़ा कंफ्यूज करा। तो चलो रेडिशन
हो गया?
नहीं सर, सीनियर
ऊपर दिखाओ, नहीं आया
सर। ये पंक्चर हम करेंगे,
नहीं ऊपर तो दिखाओ।
नहीं आप करें ना,
मैं तो कर रहा हूँ।
नहीं इधर से करें।
अच्छा ऐसे करो, ऐसे कैसे बोले?
चले सही है, आप भी मैं करता हूँ।
सर
वायर तो पीछे करो।
ठीक है, आपको वायर बहुत वो है ना,
वायर तो हमारा ऑपरेटर वैसे एक बात है,
ये
भाईजान सब कुछ नहीं निकाला।
क्या कर रहे हैं?
सर ले जाओ आप ले जाओ।
अब वायर तो ऊपर
ये मेरे ख्याल में ये काम जो है ना, ये एक बंदा करे, क्योंकि अब दो बंदे कर रहे हैं ना, तो आपके मतलब कोऑर्डिनेशन सही नहीं आ रही।
रिलैक्स होकर आराम से करें, टाइम
बस ये
नहीं, ये लूप के साथ नहीं जाना चाहिए।
इसके साथ ऊपर करें ना सर, शीट ऊपर करें, शीट ऊपर करें, शीट ऊपर करें, शीट ऊपर करें, वायर करें, शीट ऊपर करें, शीट ऊपर करें,
बस ये
ठीक है, चला
बस
गया।
गया,
ठीक है, अब होल्ड करें,
बस सही है।
आइए।
अब ये वायर
इसको नहीं,
जब तक ये वायर नहीं निकलेगा ना, इसमें नीडल पिक नहीं करेगा। ये वायर निकलेगा फिर जो है ना,
असल में ये तो ऑलरेडी पहले से हो। अब हम ये डाल देंगे।
अब आप सिलेक्ट करेंगे यहाँ से ऑप्शन,
नहीं ये है ब्रोकन ब्रोड
सर, यहाँ से सिलेक्ट करें आप आटे ब्रोकन ब्रो, सेटल नीडल, पंक्चर नीडल,
ये ब्रोकन थ्रो नीडल है।
जी आप उसे सिलेक्ट करेंगे।
अच्छा, अब इसको आप ये देखिए, ये कॉर्डली आप इधर खड़े हैं ना, तो यहाँ पे इधर 3 o'clock है, इधर 9 o'clock है। ये घड़ी जो है ना, ये इस तरफ देख रही है, ठीक है। इसका जो है ना 3 o'clock, 9 o'clock, 12 o'clock एंड 6 o'clock।
आप लोगों ने ये आपका ये है ना, ये 9 पे, ये 9 पे।
नहीं ये इसको
ये जो इसका पॉइंटेड वो है ना,
यहाँ से 3
दैट शुड बी एट 3 o'clock। अगर ये 3 o'clock पे नहीं होगा तो ये आगे नहीं जाएगा।
ऊपर दिखाएगा, फ्लोरो चल रहा है, ऊपर चलेगा। ये 5 आदमियों में काम है। एक मिनट,
रियाना जिंदा है अभी तक? आई नहीं है वो।
अब ये
ये
नीडल
देखिए,
अभी भी चलाती है।
यहाँ नीडल आपको नजर आ रहा है।
हाँ जी,
ठीक है।
बुढ़ापा भी आ गया।
अच्छा, ये आप उधर देखें उस स्क्रीन,
ये देखिए, ये कुछ कह रहे हैं ना,
नहीं वो स्क्रीन आप देखें, आप इस साइड पे आ जाए, इधर एक रेड मार्क आ जाएगा, वो पीछे खींचे।
ये तो कम से कम 2 फिंगर का
नहीं,
होता है।
पीछे खींचे।
सर
ये इसको जो है ना, आप इसमें ये ना देखें कि कितना डिस्टेंस रहता है। आप ये वर्चुअल जा रहे हैं ना, तो इधर आपको ये चीज़ नज़र आ जाएगी, तो आप इधर कैलिब्रेट करेंगे। आप पीछे ले जाएं, ये चीज़ ख़त्म हो जाएगी, ख़त्म। ठीक है, अब आहिस्ता आहिस्ता जाएं, आहिस्ता जाएं। जब ये अपीयर होगा उसी वक्त पे कैलिब्रेट, स्लो स्लो स्लो, बस। अब पीछे जाएं। हाँ, ये देखें, फ्लश में आपको बताता हूँ क्या है। हाँ, अब बहुत ही स्लो जाएं, जो ही ये अपीयर होना उसी पॉइंट पे आपने वो, बस इनफ। इधर ये रेड मार्क नजर आ रहे हैं ना, इससे आगे नहीं जाना है। ठीक है, अब इसी पे हम कैलिब्रेट करेंगे।
कैलिब्रेट लिखें,
ये लिखा है कैलिब्रेट, कर लें। ठीक है, अच्छा यार इसको फ्लश करें,
फ्लश नहीं किया आपने,
इसको फ्लश करें।
अच्छा, प्रोसीजर में क्लिक करना।
हाँ, ये इसको फ्लश करें। ये देखिए, इधर एक आ जाएगा सेलाइन फ्लश। ठीक है, फ्लश सेलाइन
हो गया।
अब हम कल तकरीबन आधा घंटे तक किस तरह फ्लश सेलाइन ले लें या इसमें एयर ले लें, जो ले लें। तो फिर आखिर में पता चला कि एक बंदे से हमने बात की, उसने कहा सेलाइन फ्लश इसमें वर्क
नहीं, वो तो 2 फिंगर्स का होता है ना, ये तो यहाँ कैलिब्रेशन, ये तो बहुत दूर है।
ये सही
उस पे नहीं जाना है, उस पे नहीं जाना है। लेकिन उसको डायरेक्शन उसका 3 o'clock पे रखना है।
3 o'clock
है तो 3 पे
बस 3 पे
3 o'clock के हिसाब से पूरे असेंबली को रोटेट करना है, सिर्फ इसको रोटेट नहीं, क्योंकि अकॉर्डिंग टू डॉक्यूमेंट आपकी
ये पूरी जाएगी।
यस, उसको अकॉर्डिंग टू डॉक्यूमेंट्स 3 पे पूरा असेंबली।
ये देखें, जिस वक्त आप, मैं आपको वो सेक्शन तो आपको वो करेंगे, लेकिन ऐसे आपका ये आएगा ना, यहाँ मुलन शीट है, तो अगर आप रोटेट करते हैं तो ये, इसका पर्पज़ ये है कि अगर ये 3 o'clock पे है, जिस डायरेक्शन में ये चीज़ है उसी डायरेक्शन में आपका मुलन शीट है। समझ आ गई ना? तो ये आप एक साथ असेंबली को रोटेट करेंगे तो टिप भी मूव होगा। अगर आप सिर्फ इस चीज़ को रोटेट करेंगे, मूव तो होगा लेकिन वो इसी तरह नहीं होगा। तो ये सारी जो है ना असेंबली आपने इसी तरह पकड़ा होगा, ये 1 फिंगर या 2 फिंगर जो भी, मतलब अगर आप ज़्यादा वो कर रहे हैं तो लेकिन 2 से वो खतरा होता है जिसमें मुलन शीट पंक्चर हो सकता है। तो आप 1 फिंगर रख लें, वहाँ पे देखें कि नीडल आउट नहीं है ना, तो फिर आप ये सारी असेंबली जो है ना यूँ करके 3 o'clock मतलब 6 पे आपने पंक्चर करना है, 3 o'clock पे आपने मूव करना है, ठीक है। और इन बिटवीन अगर आप ये चीज़ वो कर रहे हैं मुलन शीट और वो, तो उसमें भी आप थोड़े से मूवमेंट दे के क्लॉक एंटी क्लॉक, अगर आप कहीं पे स्टक हो रहा है तो इस तरीके से आप इसको डिसेंटेंगल कर सकते हैं।
अब इसको पुल करें।
नीडल आपकी तरह आ गई ना अंदर,
नीडल
निकालिए।
नीडल नजर आ गई। अगर 3 o'clock पे है तो नीडल आ जाएगी, अगर 3 o'clock पे नहीं है तो
ये 3 o'clock है।
सारा कुछ थोड़ा
नहीं, वैसे मैं बात कर रहा हूँ।
ये देखें,
ये जो भी होगा पहले हो गया।
अब हमने इसमें तो पिकटेल डाला नहीं है तो हम कितना नीचे आएंगे?
उसमें कोई डालने नहीं,
पिकटेल तो है ही नहीं, हम कितना नीचे आएंगे?
पिकटेल डालना है,
पिकटेल तो डाला ही नहीं हमने, पिकटेल डाला ही नहीं तो कितना नीचे आएंगे? हमें पता तो नहीं, रेफरेंस
पिकटेल भी है। आप पिकटेल का ऑप्शन दे दें, पिकटेल का ऑप्शन दे दें, पिकटेल डालें
तो आगे रेफरेंस पता लग जाए ना।
हाँ बिल्कुल।
पिकटेल सिलेक्टेड। यस, एक्चुअली आपको ओरिएंटेशन चेंज करके देखें, पीछे मुझे तो नज़र आ रहा है।
अच्छा,
नहीं
तो हम नीचे जाते हैं ना तो हमें पिकटेल नजर आता है।
क्लिक करें सर, ये इसका कोटा नहीं है, जो करना एक साइड ये पिकटेल है, ये इस साइड
चले नीचे ले गए।
हाँ ये नजर आ रहा है, पिकटेल ही चाहिए
यार, ये पिकटेल है सर। फ्लोरो अभी
फ्लोरो ही चल रहा है। ये एक बम्प तो आया भाई।
आया? ये फील हुआ या नजर आया?
वो नजर भी आया। अभी कहाँ गया?
यार
ये दूसरा
ये इसलिए नजर नहीं आ रहा कि यहाँ पे
टी को हटा दें, टी के साथ करते हैं, टी हटा दें उसको।
अब तो
नहीं, वो हमने कोशिश की है, वो हट
हो गया। अब इसको व्यू चेंज करें, व्यू
ये आरओ पे गया। नहीं, आपको व्यूज आपको वैसे समझ आनी चाहिए, मैंने नहीं देखा उधर पे वो कौन सा व्यू है।
अब उसको अब नहीं, आप उसको चेंज करें, लेफ्ट लेटरल व्यू करना है।
लेफ्ट लेटरल में है 90 के वो कर सकता हूं।
यहाँ से आप खुद ही करें।
अब एपी पे तो हो गया ना, कर दिया।
एपी में तो कर दिया, उसमें नजर नहीं।
लेफ्ट लेटरल वही क्या, लेफ्ट लेटरल
देखिए
90 के एंगल में
कुछ करें वो विदाउट।
एक ये है कि
आप सबसे बुक्स में
आयोटा से देखें कि आप
वो देखें टिल पिक मोशन,
फिर आप देखें कि आयोटा और स्पाइन के दरमियान कितना डिस्टेंस, उसकी
ये 90
तकरीबन सेंटर से
हाँ, ये इंटीरियर आ गया।
नहीं आप स्पाइन
नहीं आप बिल्कुल आप राइट लेटरल पे आएंगे,
अगर
आप राइट अब आएंगे
इंटीरियर इधर।
तो इधर आपको यार
नहीं हम कंप्यूटर सीख रहे हैं, हम थोड़ी वो सीख रहे हैं।
मैंने बताया हाँ ये आ गया, बस ये आ गया।
थोड़ा पीछे कैसे ना करें, सीधी करें, वो क्लियर पिक्चर हमें मिलेगा सर। अब चीज़ें मोर क्लियर होंगी। ठीक है, रेडिएशन थोड़ी है सर।
उससे बाहर एक चीज़ जो इन्होंने नहीं बताई है, जो आप इंटरेटेड सेप्टम पंक्चर करते हैं, जब आपका वो मलन शीत उस पर चला जाता है, उसमें पल्सेशंस होती हैं, जस्ट लाइक आर्टीरियल पल्सेशन। वो अगर आप फील करते हैं तो यू शुड बी वेरी कंफर्टेबल। अगर आयोटा पे नहीं है आप और पल्सेशन फील हो रही है तो दे आर सेप्टल पल्सेशन एंड दैट्स नाइस।
अब 3 पे है ना, अब इसको
60 में चला गया।
90 पे करो, 90
इसकी जो सारी हम टीचिंग और वो है वो 90 पे है।
90 पे
90 पे जाएं। 90 पे क्या होगा?
नहीं बस सही
स्पाइन
है।
ये जो sternum
मिडिल के अंदर है बिल्कुल। स्पाइन से अगर वो मिडिल के अंदर है। अब ये नहीं ये आ गया।
ये लेटर बहुत नीचे आ रहा है।
ये लेटर
ये बहुत पीछे।
sternum and spine।
जगह तो सही लग रही है।
यही है जगह।
करें सर, पंक्चर करें, खैर है। नीडल थोड़ी सी
नहीं, आपने उसको 5 o'clock पे लेके गए।
हाँ 5 पे लेके गए
पूरा।
हाँ मैंने कर दिया यहाँ से।
चलो पंक्चर करो, चलो पंक्चर करो, दर्द मारो।
पहले थोड़ी सी डाई देनी है, देख सकते हैं।
अगर आप स्टेन करना चाहते हैं सेप्टम को तो बेशक आप
निडल को
यहाँ से
यही डाई दिए
ये है।
हाँ
ये देखें। फिर उसके बाद
चले सेप्टम नीडल थोड़ा आगे करो, हल्का सा उसके टिप पे ले जाओ, तब ये स्कैन करेगा।
असल में अभी तक वो आई नहीं है पंक्चर निडल, और वहाँ वो शो कर रहा था, स्टॉप कर दिया था।
उधर टिप पे
कहाँ है?
आगे नहीं
अब डिटेक्ट अब आपकी नीडल डिटेक्ट होगी।
सर इधर डिटेक्ट हो गई।
इंसर्टेड विदाउट फ्लशिंग। अब फ्लशिंग दोबारा करें।
वेट अभी आएगा।
नहीं वो
हाँ
यही है। इसको वेट करें, इसको वेट करें, थोड़ा टाइम लेता है।
ये 5 o'clock।
आपने फ्लोरो पेडल से पाँव हटाया है।
नहीं
सर नीडल 12
फ्लोरो नहीं सीनी पे
नीडल 12 पे है सर।
नहीं वो कह रहे सीनी कह रहे हैं फ्लोरो वो कह रहा है सीनी कर रहे हैं।
रेडिएशन डोज इज
ओहो ठीक है।
अच्छा
चलो सीनी
करो
हाँ करो
करो
करो सीनी कौन से रेडिएशन में कर लोगे?
30%।
अच्छा इसमें यहाँ पे भी नजर आता है। आप अगर इधर देखें ना,
आप नीडल को कहाँ घुमा रहे हैं?
ये है ना
इधर से आप
सर ये देखिए 9 o'clock में क्या कर रहे हैं आप?
ये 3 o'clock यहाँ आ रहे हैं ना।
व्यू कौन सा है? Structure, we are all 3D. So if you are confirmed with 3D, it has happened with all of us. Because टेक्नीशियन बता दे
निडल बस जोर लगाने की
बहुत ही
फ्री साइड में
जब कर लेते हैं बाहर।
चलो जा देखो
ये देखो
Thank you. Okay. Next